Welcome to our channel Medicine A to Z. Today we are going to discuss management of ST elevation MI. What is the goal of therapy? The main goal of therapy in managing ST elevation MI is to minimize the risk of mortality and also minimizing the permanent heart damage resulting from the myocardial infarction. As we know, the mainstay of treatment is thrombolysis, but the time is golden here. The benefit from the thrombolytic therapy is greater when it administered within 2 hours of the symptom onset, but the survival benefit progressively reduces with the delay in the therapy. The ST elevation MI is a condition that you have to diagnose then and there rapidly. Quick diagnosis of ST elevation MI requires only the presence of symptom indicative of acute coronary syndrome, such as chest pain, shortness of breath, or the sudden cardiac arrest, along with the confirmatory ECG. You don't need to have the troponin values to diagnose ST elevation MI. What are the characteristic symptoms and signs? Chest pain or the chest discomfort. This can be radiated to your left arm or the jaw. Dyspnea, ventricular arrhythmias, cardiac arrest, and syncopes, and there can be associated autonomic symptoms like vomiting, nausea, sweating, and atypical symptoms such as malaise, weakness, or back pain. All can be there in ST elevation MI. What are the classical ECG findings you can see in ST elevation MI? As name implies, first it can be ST segment elevation with standard lead placement. Second, you may see new onset left bundle branch block. Third, there can be ST elevation with the posterior or right-sided leads. There can be other risk ECG findings, such as De Winter sign, transient ST segment elevations. What are the general measures you have to take when you have a ST elevation in my patient? As you know, we should monitor the blood pressure, heart rhythm, and the oxygen level continuously, because this patient can go into a cardiogenic shock at any point, or it can be new onset arrhythmia. What are you going to do as a laboratory studies if you have a ST elevation in my patient? You should look for the kidney and the anemia, thrombocytopenia, coagulopathy, and any metabolic abnormalities, because all these can impact what you are going to do, especially with PCI and thrombolysis. Additionally, you should obtain blood for troponin, but remember, management of ST elevation MI does not require elevated troponin levels. Chest X-ray is recommended for the patients with ST elevation MI to check the alternative causes of the chest discomfort and to assess any potential complications arising from the myocardial infarction. Before you start your thrombolysis therapy, you should look for the life-threatening conditions too. Whether there's any cardiogenic shock, whether there's features of heart failure, whether there's a features of aortic dissection, which can be rarely occur with ST elevation MI and can be present with tear in back pain, and the potential coagulopathy and the thrombocytopenia, which can lead to potential life-threatening complications after thrombolysis. These are the key factors that influence the choice of reperfusion strategy. First one, the time delay between the first medical contact and the performance of the PCA. It should be less than 120 minutes. Second, the time from the symptom onset to the presentation. Third, you should consider whether there's any presence of cardiogenic shock. And you should be certain about the diagnosis. Contraindications to PCI or fibrinolysis. High risk factors that favor no reperfusion. These are the routine medicines that we use in acute setup of ST elevation MI. Aspirin use always if there's no allergy to prevent the platelet aggregation. Nitrates. In patients with ST elevation MI, nitrates can reduce the symptoms of chest discomfort, heart failure, as well as the hypertension. However, we should be cautious because it can produce profound hypotension in patients with right ventricular infarction, aortic stenosis, and who have received recent sildenafil. Beta blockers. We use beta blockers for most of the ST elevation MI patients who do not have shock, heart failure, bradycardia, or any heart block. Statins in patients with ST elevation MI who do not already take statin. Statin typically started as soon after the presentation to the hospital. Morphine and oxygen we used with indications. If there's severe pain, morphine is obvious, and oxygen should be guided with the pulse oximeter because using oxygen in a liberal manner is controversial. What are the factors that influence on initiating reperfusion therapy with PCI or fibrinolysis? The time is golden, as I mentioned earlier. If we can offer PCI within 120 minutes after the presentation to the hospital or ETU, you should definitely go for PCI. But if you can't offer PCI within 120 minutes, then you should consider whether the time of onset of symptoms is more than 12 hours or less than 12 hours. If it is more than 12 hours, you should go for fibrinolysis, not for PCI. But the onset of symptoms less than 12 hours, then you should consider whether there's any contraindication for the fibrinolysis. If there's no contraindication, you can go for fibrinolysis. But if the patient is having contraindication for fibrinolysis, but the onset of symptoms are less than 12 hours, then go for PCI. So once you got your fibrinolysis, you should analyze whether there is any ongoing ischemia. If there's ongoing ischemia, we should refer him for PCI, urgent PCI. But if there's no evidence of ongoing ischemia, then we can arrange non-urgent PCI later. So this is the main guideline for initiating the reperfusion therapy.
Stay updated with the latest in medicine. Subscribe to our channel for comprehensive videos covering the latest updates in the field.